Welcome to the deep dive. We take complex topics, sort of untangle them, and give you the clearest takeaways. Today we're tackling something really fascinating, but definitely complex. The world of chronic lung conditions. We're going to pull apart three conditions that are distinct, but, well, also surprisingly connected.
That's right. Our goal today is to really get clear on cystic fibrosis, bronchiectasis, and asthma. We'll look at, their unique causes, how they actually present in people, and the different ways we manage them. But just as importantly, we'll highlight those crucial links between them. It helps paint a bigger picture of respiratory health.
Okay, great. Let's kick things off then with cystic fibrosis, or CF. Now, my understanding is this isn't just a lung issue. It's genetic. An autosomal recessive exochronopathy, my sources say. Sounds technical. Basically a problem with glands secreting stuff, and it seems more common in Caucasian folks, Northern Europeans. But what's really going on underneath?
Yeah, what's truly fascinating here is that CF boils down to a mutation in just one gene. It's called the cystic fibrosis transmembrane conductance receptor gene, or CFTR for short. You can think of the CFTR gene as providing instructions for a tiny gatekeeper, right? A channel controlling chloride and water moving in and out of cells in many glands. When that gene's mutated, the gatekeeper doesn't work properly. Chloride and water transport gets messed up. And the result, instead of normal, thin, slippery secretions, you get thick, sticky, viscous mucus. And this isn't just in the lungs. It gums up the works in the pancreas, sinuses, intestines, liver, even the genitourinary tract. It's pretty incredible how one tiny genetic error can cause such widespread problems throughout the body.
Wow, okay, so one faulty cellular gate messes up almost everything. How does that actually look in a person, especially early on? What are the first signs you might see?
Well, the ways it shows up are incredibly diverse, right from infancy, actually. About 20% of newborns might have something called meconium ileus. That's a delay in passing the first stool, which can block the bowel. Other early signs, things like failure to thrive, prolonged jaundice in newborns, diarrhea because of malabsorption, even rectal prolapse. But here's an interesting point. The lungs are usually completely normal at birth.
Really? Normal at birth?
Yeah, but here's where those connections start coming in. CF is actually the most common cause of bronchiectasis here in the U.S., and that is about the lungs characterized by that persistent cough, really thick, often pus-like sputum, and getting lung infections over and over. The airways in CF patients tend to get colonized by specific bacteria. You often see Pseudomonas aeruginosa. It can be especially sticky or mucoid in adults, and also Staphylococcus aureus.
So the lungs start okay, but become a major problem area.
Yep.
And beyond those first signs in babies, what other parts of the body feel the impact of this thick mucus as kids get older?
Yeah, beyond infancy, those recurrent lung infections are a big one, especially with Staph aureus and Pseudomonas in older kids and adults. Chronic sinusitis, nasal polyps, very common too, and the digestive system really takes a hit. There's malabsorption of fat-soluble vitamins A, D, E, and K that leads to fatty stools called steatorrhea and chronic diarrhea. Recurrent pancreatitis is a serious concern, sometimes leading to pancreatic insufficiency where you need to take enzyme pills. You can also see issues like distal intestinal obstruction syndrome, even biliary cirrhosis in the liver. And for men, the impact is significant. About 95% experience infertility due to azoospermia, which is often caused by the vas deferens being absent from birth.
Okay, given how many systems are affected, how do you actually pin down a CF diagnosis? Is there like a definitive test?
Absolutely. The gold standard, the most accurate method, is the sweat chloride test. We measure the chloride level in sweat. If it's 60 millimole or higher on two separate tests after giving a drug called pilocarpine to induce sweating, that's diagnostic. Other clues help too. Chest x-rays might show signs like bronchiectasis or hyperinflation. Lung function tests usually show an obstructive pattern that doesn't really reverse with medication. And of course, genetic testing, CFTR gene sequencing can confirm the specific mutation, especially if the sweat test results are borderline. There's also a test looking at nasal potential difference.
So once you have that diagnosis, managing it sounds like a huge undertaking. It's got to be a multi-pronged attack, right?
Oh, definitely. It requires really comprehensive management. For the airways, it's about clearance. So bronchodilators to open airways, mucolytics to thin mucus, antibiotics for infections, decongestants sometimes. Inhaled meds like Dornase alpha or hypertonic saline are key for mucus clearance, usually alongside daily chest physiotherapy, physically helping to loosen secretions. Glucocorticoids might be used for inflammation. Diet is absolutely critical because of the malabsorption. High fat, high calorie intake is crucial. We're talking, 2,500 to maybe 3,700 calories a day, plus those supplemental fat-soluble vitamins. Pancreatic enzyme replacement with meals is standard if the pancreas is insufficient. And vaccinations are vital flu shots, pneumococcal vaccine to prevent serious infections. A huge advance recently has been CFTR modulators, drugs like ivacaftor, lumacaftor. They actually target the underlying faulty protein for many patients. But connecting back to the bigger picture, pulmonary disease is still the most common cause of mortality in CF. So catching and treating lung exacerbations quickly and aggressively is paramount. That often means specific IV antibiotics, maybe vancomycin for Staph aureus, or things like amikacin, ceftazidime, or Cipro for Pseudomonas.
That makes total sense, especially since you said CF is the #1 cause of bronchiectasis in the U.S. So let's pivot to that now. What exactly is bronchiectasis when it's maybe not caused by CF? How does it differ?
Right, so bronchiectasis itself is a chronic lung condition where the bronchial airways become permanently widened or dilated. They're irreversibly damaged. And alongside that, the mucociliary transport system, think of it as the lung's self-cleaning mechanism stops working properly. It's essentially lasting structural damage.
Okay, permanent, irreversible widening and damage. If CF is the main culprit, what else leads to this kind of long-term airway problem?
Well, while CF causes about half the cases stateside, other things can definitely trigger it. Recurrent severe lung infections are a big one. If it's not CF, Haemophilus influenza is often involved, though Pseudomonas can still pop up. Other causes? Sometimes it's an inhaled foreign object that wasn't removed or airway tumors. Certain conditions like alpha-1 antitrypsin deficiency, some autoimmune diseases like rheumatoid arthritis, fungal infections like aspergillosis, or various immune deficiencies can also lead to it. What happens is this cycle of inflammation and infection damages the airway walls, making them weak and dilated. The mucus then pools because it can't be cleared, leading to more infections, more inflammation, more damage, airway obstruction, and eventually scarring around the bronchi. And this damaged environment, unfortunately, makes it easier for certain bugs to move in, especially Pseudomonas, Mycobacterium avium complex, or Aspergillus.
Sounds like a nasty cycle. Damage leading to infection, leading to more damage. What does that actually feel like for someone living with bronchiectasis? What are the classic symptoms?
The hallmark symptom is usually producing a lot of sputum every day. Thick, sticky, often dark brown or greenish, kind of mucopurulent stuff. People also experience shortness of breath or dyspnea and sometimes pleuritic chest pain, that sharp pain when breathing. Hemoptysis, coughing up blood, can happen too if small blood vessels in the airways get eroded. That can be quite scary. And then more general symptoms like fatigue and weight loss are common too. When listening to the lungs, you often hear crackles, especially at the lung bases, maybe some wheezing or raunchy.
And how do you confirm this diagnosis? Imaging must be key to see that permanent damage, right?
Absolutely. A regular chest x-ray might show some abnormalities like tram tracks or increased markings, but it's often not specific enough. The preferred test, the go-to imaging, is a high-resolution CT scan, or HRCT. That scan really shows the detail. You can see the thickened bronchial walls, the dilated airways. A key sign is that the airways don't taper normally like they should. They might look like parallel lines, the tram track sign you mentioned. And the most classic finding is the signet ring sign. That's where a dilated bronchus right next to its accompanying pulmonary artery looks like a ring with a stone. The airway is much wider than the vessel. Lung function tests usually show an obstructive pattern that doesn't fully reverse with bronchodilators. And critically, because of the strong link, you always test for cystic fibrosis as well.
Okay, so once it's diagnosed via HRCT and maybe other tests, how do you manage bronchiectasis day to day? Is it mostly about clearing out that mucus and fighting infections?
Broadly, yes, that's the focus. Conservative management centers on airway clearance, so techniques like chest physiotherapy, using mucolytics to thin secretions, postural drainage. Inhaled bronchodilators and sometimes corticosteroids can help manage symptoms too. And like with CF, getting those flu and pneumococcal vaccines is really important for prevention. Antibiotics are crucial for exacerbations. If you don't have a sputum culture back yet, maybe an oral fluoroquinolone. If you know the bug and it's sensitive, drugs like amoxicillin or macrolides might work. For tougher bugs, like those producing beta-lactamase, you might need amoxicillin clavulanate, other macrolides, cephalosporins, doxycycline, or fluoroquinolones. If Pseudomonas is the culprit and sensitive, ciprofloxacin is often used first. For resistant infections or really severe flare-ups, IV antibiotics like amyloglycosides, ceftriaxone, or different fluoroquinolones might be necessary, sometimes using antibiotic cycling strategies. If someone has massive hemoptysis, coughing up a lot of blood, that's an emergency. Bronchial artery embolization or even surgery is the first step. And surgery might be an option for severe, stubborn cases if the disease is limited to just one area of the lung.
Okay, we've really unpacked the genetic basis of CF and that irreversible structural damage in bronchiectasis. Let's switch gears now to asthma. Asthma is incredibly common. We hear about it all the time. How does it fit into this landscape? It seems different from CF and bronchiectasis. What makes it distinct?
Yeah, asthma is a whole different ballgame, really. Unlike CF's genetic defect or the fixed damage of bronchiectasis, asthma is fundamentally about the airways overreacting. It's primarily an inflammatory condition where the airways are hyperresponsive. It can start at any age, but it's most common for it to begin in childhood. And it's important to note there are disparities. Hospitalization and death rates from asthma are significantly higher among Black individuals, especially in the 15 to 24 age group.
So not thick mucus like CF, not permanent widening like bronchiectasis. It's about the airways being overly sensitive and inflamed. What's actually happening at the biological level?
Exactly. There are three core components happening in asthma. First, there's airway inflammation. This is kind of the baseline problem. Immune cells like mast cells and eosinophils get activated, often through IgE-related pathways, releasing chemicals like leukotrienes that cause inflammation. Second, airway hyperreactivity. This means the airways are twitchy, right? They overreact dramatically to triggers that wouldn't bother most people. It's like a type I hypersensitivity response, leading to muscle tightening, excess mucus, and damage to the airway lining. And third, bronchoconstriction. This is the result. The airway walls thicken and the passage narrows because of that inflammation and smooth muscle squeezing. That's what causes the wheezing and makes it hard to breathe.
Okay, so that trio.
Yeah.
Inflammation, hyperreactivity, and the actual narrowing. Does asthma always look the same, or are there different types? And what kinds of things typically set off these reactions?
Good question. No, it doesn't always look the same. There are different phenotypes. Allergic asthma is the most common type, usually starting in childhood. It often goes hand in hand with other allergic conditions, eczema, hay fever, food allergies. Exposure to an allergen can cause immediate symptoms or sometimes delayed ones. Then there's non-allergic asthma. This tends to show up more in adults and might involve different inflammatory cells like neutrophils. As for risk factors, the biggest one is a CHETP that's having a genetic tendency towards allergies. Family history, air pollution, obesity, secondhand smoke, being male in childhood, these also play a role. And the triggers, they're everywhere. Common allergic triggers are things like pet dander, pollen, mold, dust mites. Then there are non-allergic triggers like exercise, especially in cold, dry air that causes exercise-induced bronchoconstriction. Also inhaled irritants like smoke or strong fumes, respiratory infections like cold, even strong emotions or stress. And certain medications can be triggers too, like aspirin, NSAIDs, and beta blockers.
So a huge range of potential triggers. What does an asthma attack or flare-up typically look and feel like? How would someone recognize it?
The classic triad of symptoms is usually episodic shortness of breath, dyspnea, wheezing, and cough. The cough is often worse at night. These symptoms are often brought on by those triggers we just talked about, or they can just happen. People might also complain of chest tightness or feeling tired. A key thing about asthma is variability symptoms can change a lot in intensity and over time, often being worse at night or early morning, how severe it might get. Clues include if someone's needed intubation before or had hospital or ICU admissions for asthma. On exam, between attacks, things might sound totally normal. But during a flare-up, you'll likely hear that high-pitched wheezing sound, especially when breathing out, and the exhale phase is noticeably longer. In really severe attacks, there are danger signs. Not being able to speak in full sentences, leaning forward in that tripod position to breathe, a silent chest, which is bad, meaning very little air is moving confusion, or something called pulsus paradoxus, where blood pressure drops significantly when they inhale.
Okay, given that symptoms can come and go, how do you definitively diagnose chronic asthma? It's not like the airways are always narrowed.
That's a crucial point. The gold standard for diagnosis is spirometry lung function testing, done both before and after giving a short-acting bronchodilator medicine. We're looking for reversible airflow obstruction. So initially, we might see a low FEV1, the amount of air you can force out in 1 second, and a low FEV1 FVC ratio, usually under 70%. The key is showing significant reversibility. That means after taking the bronchodilator, the FEV1 or FVC improves by at least 12% and by at least 200 milliliters. That shows the obstruction wasn't fixed, it was reversible. Now, if someone's symptoms strongly suggest asthma, but their baseline spirometry is normal, we might do a bronchial provocation test. Using something like methacholine to deliberately trigger a mild narrowing can confirm that hyperreactivity, or an exercise challenge test if symptoms mainly happen with exertion.
Right, proving that reversibility is key. Once it's diagnosed, what's the overall strategy for managing asthma long-term? What's the main aim?
The main goal is to get control of the symptoms and, importantly, prevent future attacks or exacerbations. Management basically falls into three buckets. One, long-term controller medications. These are taken daily, usually inhaled, to reduce that underlying airway inflammation. Two, reliever medications. These are used as needed for quick relief when symptoms flare up. Three, add-on therapies for people with severe, difficult-to-control asthma. Short-acting beta agonists, or SABAs, like albuterol, are the mainstays for quick relief. They work fast to open the airways. Inhaled corticosteroids, or ICS, are the cornerstone, the first-line treatment for long-term control because they target the inflammation. And this is critical. Long-acting beta agonists, LABAs, are never used alone for asthma control. They're always combined with an ICS, and they are not rescue inhalers for sudden symptoms. Other controllers might include things like mast cell stabilizers or leukotriene modifiers.
Okay, definitely not a one-size-fits-all plan. How do clinicians figure out which combination works best for someone long-term, and how do they adjust it if things change?
It's managed using a stepwise approach. You tailor the therapy based on how well symptoms are controlled and what the lung function, FEV1, looks like. For very mild, intermittent asthma, that's step one, maybe just using a SABA when needed is enough, or perhaps a low-dose ICS combined with formoterol, a specific LABA, used as needed. For mild, persistent asthma, step two, the preferred approach is usually a low-dose ICS taken every day. If symptoms are more frequent or severe, you step up. For moderate persistent step 3, a combination of a low-dose ICS plus formoterol used for both daily maintenance and as the reliever inhaler is often preferred now. Then you get into severe persistent asthma, steps 4, 5, and 6. Here you might need medium or high-dose ICS LABA combinations. You might add other types of inhalers like long-acting muscarinic antagonists or LAMAs. And for the most severe cases, there are biologic therapies, injectable drugs like omalizumab or dupilumab that target specific inflammatory pathways. Importantly, if someone's asthma is well controlled for about 3 months, the goal is always to try and step down the therapy to find the lowest effective dose that maintains control.
Well, we have certainly covered a lot of ground today, navigating through this really complex landscape of chronic lung conditions. We started by sort of unpacking cystic fibrosis, getting into its genetic roots, and how that one faulty protein leads to thick mucus everywhere. Then we shifted to bronchiectasis, focusing on that permanent structural airway damage and its various causes, including that strong link back to CF. And finally, we explored asthma, the condition defined by those dynamic reactive airways, driven by inflammation, hyperreactivity, and that reversible narrowing. We've definitely untangled some complexity, but also, I think, highlighted the clear differences and those interesting connections between all three.
Absolutely. And as we finish up this deep dive, here's something maybe for you, the listener, to think about. How does really understanding the distinct causes, the mechanisms, and the different management strategies for these conditions, how does that knowledge potentially empower you? Does it change how you engage with health information, or maybe how you advocate for yourself or someone else dealing with respiratory issues? Does it spark more curiosity about the details of lung health?
That's a great question to leave us with, something definitely worth pondering. Thank you so much for joining us on this deep dive today. We hope you continue your own journey of learning and discovery. Until next time.